Yeah.
Hey, everybody. I don't really feel like I need a microphone, sir. Nice and close in, I'll use it anyways, for folks on Zoom. Well, welcome everyone. It gives me a great deal of pleasure to be able to introduce our guest speaker for our research grant rounds. College of Health Sciences here today, Dr. Sarah Bowen. Dr. Bowen received her PhD in clinical psychology from the University of Washington and has served on the faculties of the University of Washington and Pacific University. Her clinical and research interests over the past 20 years have focused on mindfulness-based approaches to addictive behaviors, with a primary concentration on substance use disorders. She's been the recipient of a number of NIH R01 awards and authored numerous articles and is the lead author of the Mindfulness-Based Relapse Prevention Clinician's Guide. Dr. Bowen has worked internationally with colleagues in the UK, Sweden, China, Taiwan, and Brazil. She's conducted clinical trials in prisons, community treatment centers, and VA medical centers. Her work continues to center on high-risk, low-resource individuals, helping understand how certain behaviors function in their lives and what changes might best serve them. So it's a great pleasure again to introduce Dr. Sarah Bowen.
Thank you, Mike. I have heard a number of wonderful things about Boise prior to coming here from Mike and others, and so far they've all been true. I'm just really enjoying my time here so far. So thank you for the invitation and thank you all for being here today. I am going to talk about this mindfulness-based approach to addictive behaviors. Give you kind of an overview of what we're going to cover. I want to start with start at the beginning. How did this all start out? What were the kind of seeds of the work we've been doing over the years? So we'll talk about the background, the theory underlying this work. And the program specifically I'll talk about today is called Mindfulness-Based Relapse Prevention. That's what I've been working in for the past 20 years, I guess. And then we'll show you kind of what that looks like inside the clinic. Then we'll talk about some of the trials. There have been several trials now. I'll focus on two. They're the two largest trials. The primary one, primary randomized trial, I'll spend some time on, and then I'll talk to you about a current trial that we're doing. Also, I'll touch on some adaptations. We've been doing this long enough that people are learning that not one size fits all. Different populations, different contexts need different things. So I'll talk a little about some the work that folks are doing to adapt this to other settings. Yes, and also looking at moderators and mediators. In other words, like how does this work? What are the mechanisms underlying this? Why are we seeing outcomes? What's driving that? And also for whom? Are there some people that this suits better? Some people maybe it doesn't work so well for. And then implementation. Yes, I'll talk about our current study that we're doing. We're really trying to get this work out of the labs and into the streets more, and trying to make it as accessible as possible for as many people around the world, ideally, as are interested in this. So that's what we'll cover. Okay. I started my graduate work with Alan Marlatt, who worked in addictive behaviors at University of Washington. And this was back when now, like, mindfulness research is kind of everywhere. A lot of people are involved in it. Back in 2002, it was like a career-ending thing to say that this is what you're doing. So you kind of did your CBT work and then went in the basement and like did little unfunded studies. So that's when I entered this. And then in 2002, he wrote this seminal article about how the tenets from Buddhism and secularized Buddhism and mindfulness might be useful for treating addictive behaviors. And one thing he said that really stood out is that this is essential. Which one can I read from? To understanding how the mind behaves, how thoughts and expectations can either facilitate or reduce the occurrence of addictive behavior. And that sort of summarizes everything that we did after that. The first study, again, this is when I was entering grad school. The lab was doing a study of Vipassana meditation. I don't know if folks are familiar with that. It's a Buddhist, very traditional form of meditation. And a group of folks was teaching this, offering this in a jail. And the jail was a treatment-rich facility. Most people there were on some addictions-related kind of charge, possession. And the folks who were doing the group reached out to Alan and said, "Do you want to study this? Because it seems like there's cool stuff going on." And he said, "Absolutely." So we went in there, interviewed before, after, and then we were very curious about what happened after they were released. They were all there on fairly short-term sentences, so we wanted to follow them up after they get out of the community and see any differences for folks who took the course. So there were men and women in the course. We had 173 total. You can see primarily male in the facility, so that was in our sample as well. And you can see the breakdown here of race, ethnicity, education. And then when we followed them up, we found that 3 months post-release, those that took the course versus control had significant improvements in several areas. Substance use primarily, psychiatric symptoms, hostility, depression, anxiety, and also higher levels of optimism. And another interesting finding, we found that the changes we were seeing in substance use were partially explained by reductions in thought suppression. So people were not attempting to push their thoughts away as much and doing better than in their substance use. One caveat about this trial, it wasn't randomized. The facility and the folks teaching felt very strongly that anyone interested in this course should have access to it, and it may be their only chance. So we did a case match on gender, age, and substance use severity, but it's not a perfect design. So that caveat holds. Click. There we go. So I want to talk a little bit about after this, how we started thinking about what is the process underlying addictive behaviors, and can mindfulness, meditation, mindfulness-based approaches help? And if so, how? And what are we actually targeting in these processes? So I'll just kind of walk you through how we're kind of thinking about a behavioral lens on any addictive behavior. So there's often an external, in the beginning, an external trigger, a party, an event, whatever, have a drink, yes, okay? And then that in the beginning, leads to a behavior, and there's a reward. It's positive reinforcement. It's like, that was fun, had a drink, had a good time, I think I'll do it again. So that's positive reinforcement. You repeat the behavior because it was positive. Then over time, what happens often for people who this becomes a problem is the trigger becomes internal. So it's no longer going to a party. It's like, I don't feel good. I don't like the thoughts I'm having. I want to feel differently. I don't want to feel how I'm feeling. And then that leads to behavior. And then we have a negative reinforcement. So we're removing an aversive stimuli just to get back to normal rather than having it be positively reinforced. So that we see in the research that when there was one study and several after that where they asked folks who relapsed, what was it that happened right before you went back into use? And the number one answer is, I was feeling something I didn't want to feel. I was anxious, I was depressed, I was scared, it was whatever, but I needed to not feel what I wanted to feel. And several studies show that. Here's a quote from one of our folks, who I think wraps this up much clearer than the data perhaps. I am a trigger for me. The constant chaos in my brain is my trigger. I want to be able to chill. But the second you're not chill, you're back to chasing. So I don't want to feel this way. That's going to take it away. Of course, I'm going to do it. And then we have what Alan Marlott referred to as the abstinence violation effect often, where let's say a person has been absent for a while, they're really trying to change their behavior, and then they slip and they use again or do whatever the behavior is again. Oftentimes there's negative thoughts, shame, maybe physiological effects of withdrawal, all these kinds of things that are like not fun to feel. And that can often lead right back to the internal trigger. It's like, I knew I couldn't do it. I feel awful about myself. You know what would make me feel better? And so we can see how the cycle continues. So how does mindfulness come in? Where does mindfulness come in? So I like to keep things very simple, how I keep track of things in my head. So the definition the way I like to think about mindfulness is there's two components. There's paying attention to what's happening in the present moment. And then there's the quality of attention or the experience. How am I relating to what's happening in the present moment? So basically, what's happening and how am I with what's happening? And when we say what's happening, this direct kind of experience, it's really the direct sensations in the body, the thoughts that are occurring in the mind, the emotions that are present. Those are kind of the three data points that we have. And then we also have here what happens after those. There's judgments, there's stories about it, there's interpretations. There's all these things that one of my teachers, Sharon Salzberg, calls add-ons. Like, yes, I have a stomach ache, and now I'm like, oh, what did I do wrong? I'm Am I ever gonna feel better, whatever it is, all the stuff that our mind kind of adds on. And in traditional Buddhist literature, we talk about pain and suffering. We can also think of this as the trigger and the response to the trigger, the reaction to the trigger. There's the thing that happens, and then there's how we respond to the thing that happens or react to the thing that happens. This making sense? So mindfulness and behavior change generally. We're all conditioned to avoid aversive experiences. This has served us well over the centuries. And of course, it makes a lot of sense. Something doesn't feel good, you try and get away from it. It's protective, makes sense. The mindfulness practice is kind of countering that. So when something aversive shows up, like I'm feeling something I don't like, it's really uncomfortable, we learn to just, so we have some flexibility, sit with it and see what happens, rather than just, I'm gonna make it go away right away. Oh, this is happening, I don't like it. I'm gonna sit with it and observe, what does it actually feel like? What are the thoughts that are happening? What is emotion? How does that live in my body? These kinds of things. And this is in some way an exposure response prevention model. So the exposure is to the internal events that are happening. And the response prevention is, I'm not going to go reach for whatever. I'm going to just stay with it. Okay, does that make sense how those two go together? So it's really repeated, prolonged attentional contact is the exposure. And then the response prevention is staying with instead of making it go away or trying to escape. And this studies are pointing to this is interrupting this kind of automatic or habitual behavior cycles that we get into. So integrating approaches. So in grad school, you learn about a number of different approaches. So we were learning relapse prevention. This was Alan Marlat's cognitive behavioral-based intervention. And then also at the time, the mindfulness-based approaches were just kind of coming out. There's Kabat-Zinn's mindfulness-based stress reduction. And then Zindel-Siegel had just started working with depression with mindfulness-based cognitive therapy. So we went and talked to them and studied with them a bit, tried to see if we could kind of use some of their skills and wisdom and experience to inform what we were doing. And then also there was a lot of motivational interviewing floating around the university. So we were all trained in that as well. And what I appreciate about that and what sort of made its way into our work is very client-centered, not top-down, but very collaborative, kind of you tell me instead of me trying to tell you. And I was also, next door was this lab, Robin Kohlenberg, who is a radical behaviorist. And I was sneaking over there every now and then and learning about behaviorism and was very struck by just the logic of it and how much sense it made. So that really crept its way into this work too, in terms of reinforcing behaviors and how that works in conditioning. And so that all led to this program that we've been working with for a few years. A little bit about the program and what it looks like. It's designed to be, it's an 8-week closed cohort, at least traditionally it is. It's taken many different forms now. But initially the idea was to have an 8-week course and to have it be an incremental kind of training for people. So how many folks are familiar with mindfulness-based therapies or kind of the 8-week feel? Okay, a couple. It sort of started with Kabat-Zinn's mindfulness-based stress reduction, 8 weeks. So we all were like, okay, 8 weeks. So ours is 8 weeks. It starts with awareness, the very first session, walking in, okay, mindfulness, you don't have to sit a certain way. It doesn't have to be weird. You don't even have to close your eyes. So we start with a very simple exercise with a raisin, and this is borrowed from Kabat-Zinn. Any food item, doesn't matter, but it's a tangible external object. What happens when you bring your senses to this object? What does it feel like? What does it smell like? What thoughts are going through your head as you're doing this exercise? And then it sort of also demystifies mindfulness. It's like we can do this with a piece of food. It's not anything special that you can't do. It's accessible to anyone who's interested. And it's sort of a fun exercise too, that makes it a little less maybe intimidating. And then we move from that to taking that same awareness, but bringing it to internal, versus external object, bringing it to the internal experience of the physical body. Like take that same attention that you brought to the raisin and that same curiosity and see if you can shift it inwards. And what do your toes feel like? What do your ankles feel like? And kind of progressively move through the body, not in a relaxation way, but in kind of gathering data. What do you notice about your body? And what do you notice about your mind as you're trying to do this? Oh, I fell asleep. Oh, I'm thinking about tomorrow's meeting, mind is everywhere. So it's also noticing when the mind wanders, because it will, and then bringing it back and starting again. So this is called the body scan. I think many folks are kind of familiar with this. And then we keep exploring body sensations and move into, we start with body sensations, physical objects, very tangible, and then we move a little into things that are a little less tangible or might feel less tangible. So we start being aware of what is the mind doing? What is it like to watch your own mind and notice your thoughts? And then what's an emotion? Is it in your mind? Is it in your body? What does it feel like? Are thoughts and emotions related? And what are the nature of all these things and the interaction of these things? Oops, wrong button. So we do this through several practices, meditation practices. You close your eyes if that helps, and you just explore what's going on in the body, what's going on in the mind, what are emotions, what am I feeling? Oh, mind wandered, come back again. And then we also move pretty early on in the course to the practice of pausing in the midst of reactivity, whatever that is, like you're about to yell at someone, you're about to recoil, whatever it might be, and pausing and seeing what that feels like, what caused it, what was the trigger for it, and what does it feel like to just sit with that reactivity for a moment. And this is practice we call urge surfing, which metaphor, obviously, of a wave, and the wave is kind of the intensity of this reactivity, and it kind of moves up, and oftentimes like I have to stop it, or it's gonna take over, and playing with that, like what happens when you sit with it. We'll talk a little bit more about that in a moment. And then we also, throughout this, woven in is this sense of compassion and skillful responding. It's hard to be human. We all struggle with something. It's all of us. It's not your problem. I'm going to tell you how to be better. It's like we're all doing this together, and can we explore this together? It's part of being human. And so we have some practices around kindness and forgiveness. Also, as I'm sure you're aware, there's so much shame in addiction. So we really try and emphasize it. This is a behavior, and it's not that you're a bad person. It's that we need to look at this behavior and learn a little bit more about what's happening and why. There's a reason it's happening. So ultimately, what we're aiming for is awareness of, which brings really freedom from these patterns that perpetuate addiction and suffering. Big goal. So I mentioned urge surfing. So again, this is kind of this exposure response prevention paradigm. And so oftentimes an urge feels like it's going to keep going and going and going until we stop it, right? Like I can't stand it. I have to make this go away. And so we reach for something and it goes away. And that is negative reinforcement. So we do it again. It worked. I made it stop. I'm going to do it again. However, oftentimes when we sit with these urges or cravings, they do go up and down. They don't go up forever and ever and ever. It just feels that way, but they tend to go up and then eventually they go back down, or maybe they wave a little bit. They change over time. And so if we can learn to ride these and stay with them like they're a wave, this is the exposure portion. I'm staying in contact with something. It's not overwhelming, but I'm not running away from it. I'm staying in contact. I'm exposing myself to the aversive stimuli. And using the breath and the body to do that. Noticing sensations, not getting caught too much in the head, coming back to the body and the breath. And then trusting that they're learning from this experience that reactivity, it fades, it changes, it might come back, but it doesn't go up and up forever. And can I learn to stay with it and see what happens rather than immediately react to it? Goes down. There we go. Often, again, better said by a client, before I react to my emotions, just because I had them, because I felt them, but after we did urge surfing and stuff like that, I noticed I can actually feel what I'm feeling and not react. So we're not trying to make it go away, we're staying with it, fully feeling it, and also choosing to not react. There's another related practice, and we'll practice this one if you're willing. It's up to you. Called the sober space. This is an acronym. We use an acronym because oftentimes, as many of you are aware, sayings and acronyms are really helpful in addictions treatment. When there's a triggering situation going on, it can be really hard to access your skills. It's like, oh, how do I remember that saying? Yeah, drink, drunk, or one day at a time, or whatever it might be, that helps you like remember, oh, right, I have a choice here, I have an option. So that's why we use this acronym. And what it stands for is the S is stopping and recognizing I'm really reactive right now. I'm kind of on autopilot. I want to just do what I usually do. Can I stop and can I shift so I'm not focused on the thing and the problem? I'm focused again on my body and my experience of what's happening right now. So it really is like shifting from external heady stuff to what's happening in my body right now. What do I notice in my mind? How am I feeling? And then the O is just that, it's observing internal experience. And then we have people as much as possible sort of unhooking from that whole reactivity and coming to the body, the mind, the emotions, and then just coming to the breath. Breath for most folks is fairly neutral. So it's a way of really disengaging from that reactivity and coming just to what does the breath feel like in the body? Something that we've in the course practiced up until now is awareness of breath. And then after the attention settles a bit, expanding the attention back out again. Okay, now what's happening in the mind, in the body, in the emotions? Can I hold it all? Can I be a vessel for all this to pass through and not have to react to it? And then the R is choosing, like, okay, this is all still happening. I still feel a way I don't want to feel. I'm going to choose what I do next. It might be the same thing as I always do, but I'm choosing it. It's not just an automatic reaction. So it's kind of trying to loosen up the conditioning and put in some more agency in there. So again, we'll practice this. You can close your eyes and think about lunch if you want. Nobody will know. I'll guide you through this. So if it helps to close your eyes, you can go ahead and do so. Otherwise, maybe just put your gaze at a sort of neutral spot in front of you. And either sit with what's happening right now, just noticing what's going on, or if there's something that's kind of bothering you or a little bit triggering, nothing too big in your life, you can kind of call that into your experience if you choose. So just noticing right now, attention has been in the mind, probably listening, whatever, and seeing if you can shift in whatever way works for you, shift that attention to, we'll start with the body. Just noticing, oh, I have a body, feet on the floor, feel the chair underneath me, where are my hands, noticing maybe temperature, maybe points of tension, just kind of surveying, gathering data, what's going on in the body right now, just being a body. And then shifting to the mind. What is it like to observe your own mind? Just seeing what that's like. What's happening in the mind? It might be blank. It might be full. It might be foggy. It might be clear. We're not trying to change it, just taking inventory. What's going on in the mind right now? Is there content? Is there climate? And if mind wanders, it will just come back. And then noticing, do I have any emotion present right now, or mood or feeling? Maybe you do, maybe not. Maybe there's subtle something. Maybe there's a bunch of stuff. Again, not trying to change anything, just noticing, how do I feel right now? What's my mood or what emotions might be here? And then as best you can, narrowing your attention, focusing it in just on the experience of breath. You don't have to breathe deeply, just noticing that your body is breathing and seeing if you can really feel that experience. Maybe you notice the air in the nostrils, with the chest rising and falling, or the belly expanding and contracting. Just being curious about what does it actually feel like when the body breathes. Just staying with this as best you can. And then when you're ready, expanding back out again. So you're sort of widening the aperture of your attention. So it includes, again, the body, the mind, the mood states, the breath, all of it. And seeing if you can just be with that, letting it all play through you. And then noticing whatever you're experiencing here, you have a choice in how you respond. There may be a habitual way that you would typically react, check your phone, do whatever you do, get caught in thoughts. Notice that that's a choice. You have the choice, and you can choose how you'd like to respond in this moment. And then as you're ready, if your eyes are closed, you can allow them to open. So just briefly, I'm curious if there are any observations when you did that, or questions, or things that you noticed. Yeah,
I feel that I do on autopilot throughout my day. And when I sit with myself and like focus on my body, I feel like my chest always feels kind of heavy.
Mhm.
And my breathing feels restricted.
Yeah.
And then I went to like, that's discomfort. And I wanted to grab my phone and like Google it. Instead of like sitting with it and like figuring out how I myself like make myself feel better and what that's coming from. So
that's
my
great. I
focus.
love that. Did you notice that thought as it was happening, or is this sort of in retrospect? Did you notice that kind of
As it was
urge,
happening,
as
as-
you, like, you noticed that you had this urge to?
You said, what would you do? Would you grab your phone? And
Yeah.
I was like, I would totally do that.
How did you know? Great, yeah, thank you, thank you. Anyone else, any other experiences, or anyone just kind of check out? Think about something else, fine, happens. Okay. So that is a practice that we, in the initial 8-week program, we do it like 2 or 3 times. We now have a rolling, I'll tell you more about this, but a rolling version, so people can enter at any time, and it just kind of keeps going in perpetuity. And they do every other session, they introduce this and practice the sober space, because we found in studies when we ask people, do you use any of this stuff? Do you do the body scan? Do you do the breath meditation? Do you, it's all over the place, except 97% of people say sober space. That's kind of seems to be a very useful tool for them when they're having kind of a reactivity. So this is just very doable kind of pocket practice. Another practice we do, we call it the false refuge. This term comes from Buddhist practice. I try to secularize everything, but this one there's just no better name for it. So that's what it's called, false refuge. And what we ask people is, when you are feeling that urge and desire and you're reaching for whatever the thing is, your phone, a drink, whatever it is for you, what is it that you're looking for, that you're trying to get from this behavior or this object? And we hear things like peace, freedom, relief, fun, escape, relaxation, connection. That's what I really want. That's what I think this is going to give me, and I want that. So I'm gonna reach for it and see how it goes. And then we ask folks, okay, what actually happens? Maybe it does, maybe it works. What do you end up with? And we often hear things like anxiety, consequences, shame, loss, defeat, tension. I mean, it's just almost the exact opposite of what we're trying to get. And where we really stop here is not like, okay, how could you do this better in the future and replace this for this? It's much more just learning about this whole program, really learning about your own experiences, your own behaviors, your own bodies, your own minds, gathering data, and then you make choices. If the lights are off and you don't know what's going on, you don't have much of a choice. You turn on the lights, you can see what you're up to. It's like, okay, I can maybe have a little more agency. So that's called false refuge, because what we reach for is often it seems like a refuge, but it doesn't deliver. It's false advertising, basically. So I'm going to shift and talk a little bit about the trials that we've done, some of the trials. The largest initial trial, we did some little pilot studies, a little bit scrappy, and then the first major randomized trial that we did was back in 2014, it was published, so 2012, 2013. We were in a community-based treatment center, which is in Seattle. And so we went in and said, we'd love to offer this course. We'd like to randomize folks. They said, thank goodness, yes. So here's kind of a breakdown of what the sample looked like. High level of education, high level of unemployment. And here you can see, I won't read this all to you, but you can see the breakdown of the substances that folks use. But I will point out 82% use more than one of these, which is, it's not necessarily surprising or rare. So we took them in baseline, asked them a whole bunch of questions, did that whole thing. Then they were randomized to either this mindfulness program, MBRP, or to traditional cognitive-based relapse prevention, or to treatment as usual. So the treatment as usual, they were already doing in the clinic. It was 12-step psychoeducation. It's kind of up to the clinician, but it was more around the 12-step model. Then we followed them up 2, 4, 6 months, and then for a year out in the community. What we found, and this, I'll just kind of walk you through this here. This is a survival curve. So the longer you stay on top and don't drop down, the better. And we found over the first year, you can see the red, the MBRP there on top was, see it right there, was able to sustain their their abstinence, their time to the first drink, longer than the other groups. So they maintained abstinence. We're just not only interested in abstinence though. It's like, okay, so maybe you slip and drink and that doesn't mean you failed. Like what happens after that? How severe is this? Are you drinking less? So we also looked at the drinking time to first use. I get this back. Oh, drinking day and first use, sorry. We're looking at drugs and alcohol here. And we see a similar pattern with the mindfulness folks able to sustain abstinence. Then we looked at, here we go, the days of use over time. How severe was this use? And you can see here that in the beginning, post-treatment, and at 6 months, the mindfulness and the cognitive behavioral group are doing fairly well. They're doing significantly better than treatment as usual. But then what happens here, where are we, 12 months, is the cognitive behavioral group goes back up again. Their use, again, spikes. And there's something that happens here with the mindfulness folks where they're able to sustain a lower level of use over the year. And we see the same kind of pattern, looks a little different, but the same pattern here with drugs and with alcohol. Click, click. Oh, I'm circling things. There we go. Yeah, we can see the differences there. All right. Now, since then, that's kind of our initial trial. And we've been working with a number of wonderful colleagues, collaborators, and they're off doing other trials. And there are a lot of folks looking at specific outcomes. Our trial was a mixture of all kinds of different substances, and maybe opioid use is different than alcohol use, and does it work with methamphetamine use? So a lot of studies on that. I'll just show you a few. I won't go through each of these, but with alcohol specifically, and they saw a decrease in drinking, both, again, for both treatments, but then as we saw with the previous study, there's something about MBRP where they were able to sustain for a longer period of time. Smoking, this was done with colleagues in Brazil, and they showed MBRP had significant reduction in craving and higher rates of abstinence. And alcohol and smoking, both conditions had significant reductions. This is interesting. All of the participants were in nicotine replacement therapy, and that had an overarching strong effect. And it didn't seem to matter, at least not significantly, whether they were in this condition or that condition. NRT was kind of the driving force in that one. Both conditions had reductions. And then illicit drug use, a colleague in Taiwan, MBRP, treatment as usual, significant reductions in anxiety, depression, and positive expectancies for use. So that's just to kind of give you a little smattering of what other folks are up to out there. There's also a lot of interest in co-occurring disorders. There's, as been, you know, I'm sure you're aware, there's a high comorbidity with trauma, anxiety, depression, and substance use. So one team looked at anger management in Brazil. Mindfulness increased the anger control and expression, and also that it mediated the effect on anger expression. So measures of mindfulness were showing like, yeah, that's something that's changing, that's helping explain the changes in anger expression. And this was a grad student of mine who got an NIH dissertation grant, and she was really interested in looking at PTSD and substance use. Women randomized to MBRP or TI-MBRP. So she developed a trauma-informed MBRP that took some trauma treatment and integrated it into the standard MBRP, specifically cognitive processing therapy, which is an evidence-based treatment for trauma, for PTSD. And she found that there were some changes here and there, but at 12 months, both conditions had reductions. And at 1 month, MBRP actually had greater reductions in PTSD. So that was interesting. It was, she was actually, NIH encouraged her to have a comparison trial here, which we didn't really want to do. But so we weren't too surprised at this. I think MBRP is exposure therapy in many ways, and maybe just a pure form of that was less confusing and more consistent than bringing in some trauma-informed care. She did find, though, that the duration of formal practice, so formal practice being sitting down, setting time aside to practice these exercises, predicted the reduction in PTSD. So that seemed to be an important aspect. Informal practice, like the sober space we just did, kind of like practicing in the moment, didn't seem to drive changes. There are so many studies of informal versus formal practice, and the findings are all over the place. So there's not yet really a consistent story about that, I guess. A little more just about the research, and then we'll move to the current study. So we're really interested in mechanisms again. What's going on inside the black box here that's kind of driving these changes in outcomes? So we did a couple secondary data analysis looking at this kind of process where there's a trigger, then there's a craving, and or urge to use, and then they engage in behavior. That's kind of the stream that we look at here. We're interested in both what happens between trigger and the craving. Like I'm triggered, but I'm not craving, but also what happens if I do crave and have that urge, but don't have the behavior. So both of those junctures we're interested in looking at. So one study, we looked at secondary analysis here, the relationship between depression and craving, and found that that weakened that link between those two things, and that explains some of the changes in substance use. So that seems to be an active ingredient there, is that attenuation of the trigger craving relationship. And then we found too that formal practice moderated the relationship between craving and use. So that's basically explaining or pointing to this urge craving to behavior chain. Again, better said by a person than me. I paused and watched my breath. The urges and thoughts would keep poking their head, so it's still happening. But they got quieter and just weren't as big of a deal. I sat until I didn't feel like I had to act on these things, thoughts and feelings. Finally, I saw the situation clearly. I could make a different choice. So it's still happening, but there's some agency in how I respond versus react. Just briefly, we found a group of studies sort of converge on an interesting finding here, that there seems to be a greater reduction in craving use in people who have higher severity. So this is in co-occurring depression, in other psychiatric disorders, depressive and anxiety disorders, and more severe SUD symptoms, and the combination of SUD and high depression anxiety. So all of these are different studies pointing at like, there's certain folks who seem to have more changes or benefit more. So if you kind of think of severity on a spectrum here, it's sort of maybe this area here. What we found is maybe, what we kind of think about this is, if it's real low severity, oftentimes you find younger folks come in, they got a DUI, they're not very motivated to change their whole worldview. They're like, okay, I'll be careful, whatever, and they get out of there. And with the really extreme folks, oftentimes something else is needed. This may not be the most appropriate way of working with that. But it seems to be that there's enough suffering, not too much, not too little, but enough that it's motivating and it's right there. And I can work with this and I'm motivated, I want to do something different. Those folks seem to be responding really well to this. Finally, as I mentioned before, there's alternative versions of this. 8 weeks, closed cohort is not always reasonable. It doesn't work very well. If you have an agency of people coming in every week, and like, wait 8 weeks and you can start this course. It doesn't work. So my colleague, Katie Wickowitz, and a student of hers, Corey Bruce, came up with this rolling version. And the first trial of that was in a residential treatment center with women, and MBRP performed fewer days of drug use and problems. So drug use and consequences. And then another study of this individual format in Spain, MBRP had significantly reduced substance use and craving. And those benefits were maintained in 4 months. So it seems that the rolling format has some promise. So I want to talk a bit about the current study. This is still going on right now. And this is a longtime colleague of mine, Katie Wickowitz at University of New Mexico. And this is kind of it's 20 years later, and this is sort of our opus. It's like, this is what we ultimately want to do with this. So I just love this study. The end goal was, can this get out of just the lab and out of just private treatment clinics and even just treatment clinics and be as accessible as 12-step? That's a big goal, but that's kind of what we're looking at. So this, also we wanted to offer it for free. Like, if you're interested in coming, no barriers. Come in, stay as long as you want, as many groups as you want, leave when you want, free, so that it can be sustainable. We initially had some clinicians that we trained and have worked with offering these groups. We intentionally did not compensate them monetarily because we wanted to see if this can be a peer-led eventually kind of system. And so as we're doing this, we're identifying also people who are participating in the group who might want to be peer leaders eventually. I don't know if it's gonna work, but we're trying to see, can we get this up and rolling with support from us, but it's really kind of its own thing that can be sustainable. So the current trial is called Thrive. It's nationwide recruitment. Our facilitators are actually international, but because it's NIH funding, the participants are just nationwide. Community-based facilitators. Participants, they're all sorts of different folks. Some have received treatment, some have attempted, some are interested, but they have to be one of those things, like have some interest in something or to come to the group. Be curious about your behavior. And they're randomized either to the MDRP rolling format or to they're given referrals to other group-based treatments. The rolling groups are offered several times a week, again, to try and make this accessible different times a day. Can't come on Tuesday morning, how about Friday night? So, a little bit about the folks who showed up. Only 14% had prior treatment, 13% prior AA. And I'll just show you here the goals are interesting. We asked them in the beginning, what are your primary goals here? The most popular one, most endorsed one, is drink in a controlled manner. Not ready to quit, but I gotta change something. Abstain for now. I'm not gonna commit to forever, but for now. Abstain forever. There's a good chunk of people who have that goal. No clear goal. It's hard to read these. Harm reduction. And none of these. So that just kind of gives you a sense of what people are coming in with. And all of this is welcome. It's like, are you interested in anything about your behavior? Come on in. So we recruited, randomized baseline assessment. They were, again, randomized to MDRP referral. We have 470 people who are randomized. Then they were given an orientation session, like this is how Zoom works. This is all on Zoom. Here's an app. We created an app for this, and this is how the app works. It just has some of the practices so they can practice those between weeks. And then they were told, attend as many as you want. We have one person who's attended every week for over a year. Some people who attend once. So it really varies. And then we also asked the facilitators what their experience was. We wanted to know, is this sustainable for you guys? And if not, what would help? What are the barriers? And then we're following up for 3 years, which will be the longest follow-up in this body of research. So far, we've finished 6 months. That's where we are. We have 86 retention, not perfect, but this population, as many of you know, is pretty difficult. So we're pretty happy with that. And then we're following up in 6-month increments until 3 years. That's all. I want to definitely leave time here for any questions or comments that folks might have. Oh, yeah, please.
Do I need a microphone with Zoom or fine?
What do you think? Microphone?
You could always repeat the question.
Okay, that'll work.
With the recent study that you're in, so you're saying some people have come for 1 and then some have come for a year. So I assume you're looking at dose response in that, and so the 86 is anyone who's come at all, is that right?
Yeah, the 86, yeah, sorry, it isn't. It's the folks who we were able to get data from at 6 months.
Oh, okay.
It's the assessment retention, yeah. And we're absolutely looking at attendance, who attends more than others, dose response, all those things. Very interested in that, yeah.
And are you just looking at like the cravings and the outcomes over the 3 years, or are there other variables you're looking at?
We're measuring as much as we can get away with.
Yeah, good.
Depression, anxiety, trauma, yeah, and clearly substance use, many different indices of substance use and craving.
Well, thank you.
Yeah, thank you. I didn't repeat the question, but hopefully my answers made it obvious what the question was.
Does age make a difference at all?
That's really interesting. Does age make a difference? There's one study I didn't include here that one of my graduate students did, looking at this isn't in this trial, this is from our large trial secondary analysis, looking at younger versus older, and that age cutoff I think was 21 or 22, and did find that older adults tended to do better in MDRP than in RP. So if the older folks were with, I think it's very correlated with the severity and number of relapses, and it's like, I'm ready to do something different, they tend to do better, they have better outcomes than the folks who are younger. And we definitely saw that too clinically in groups, so like that guy doesn't want to be here, he doesn't need to change, you know, he might be fine, he thinks he's gonna be fine. That guy has been through every other thing and needs something different, so it makes sense to me. Thank you. Yeah.
To follow up on Heather's question, how about gender? Because you talked at the beginning about how most of the participants were male.
Yeah, gender. We didn't find in the main study, but it was predominantly men, so I'm not sure power-wise we could really look at the difference. But we did find in another study, secondary analysis, that women did better in groups that were majority women, half or more women. And they did worse when they were like, 2 of 10 women. So then we started doing women-only groups to see like, okay, we need to have an environment where everyone feels safe.
Sounds like physical education.
Okay. Yes, yeah, you're speaking next, okay. Yeah. So I want to look more at gender, and we of course we look at gender and everything we do, but that's the one finding that came out pretty clearly, and again, it makes sense when you sit in the room, there's 2 women and a whole bunch of men, and a lot of trauma and sexual trauma in the women's histories. Yeah, thanks.
So what the typical sessions look like? Because some folks like to come and do the full year, and do they rotating the topic, or is they kind of have a
Yeah.
guideline for
The
the
wedding sessions in the rolling format look like. So they're an hour, again, accessibility. In person, they were 2 to 2.5 hours. We were like, that feels long to me. Let's do an hour and make it just doable. So an hour long, every session starts with sort of the bow of the sober space that we just did. We call it a mindful check-in. Checking in what's happening in the body, what's happening in the mind, what am I feeling right now, how am I with this? That opens every session. And then there's one kind of topic that's pulled from the 8 sessions. So it might be like urge surfing is what we're gonna do this time, or a kindness practice. And then there's always inquiry afterwards, like tell me about your experiences. People, we've had groups of 12, we've had groups of 2, we've had groups of 1. People come and go, again, some people really consistently, some people drop off and then come back. But it's lovely. I listen to the groups. And the people who come back, they're very different from one another. It's a very diverse group of people. There's like 3 or 4 of them that are kind of long-term. And they just work together beautifully, and they're very curious they just keep coming back. They want to keep doing this and can't always maybe articulate exactly why or what's happening, but like there's something here, and I want to keep coming back and seeing what this is all about. Yeah.
Do you gather any data on like the support the individual who's participating in the program has from like family and friends?
Yes.
Because I just think if someone goes in it by themselves, it's probably harder versus if they have like a community backing them up.
Yeah, great. So question about assessing what other supports people have when they're coming into this. We do, we assess other treatment support. We don't assess family, but I know, no, I don't think we do. We don't have a measure of like family support. We've used measures of overall general social support. But I appreciate your point that's someone just doing this completely on their own versus someone who has a lot of support. And part of what we are hoping to offer is support, whether you have more or not, like come back to the group, come on back, come twice. There's one woman who comes twice a week, 2 groups a week. That's her, I think, one of her primary support. So hopefully it's offering some of that as well. Yeah.
So part of treatment is like just suggestion, talking, or there is some medications like there is the neurochemicals like GABA, melatonin, serotonin. Those also play a lot of a role in calmness and So are you including those medications in your study?
Yeah, thank you. Question about our medications or other, whether pharmaceutical or natural, included at all in this. We haven't, it's just not what I do, it's not my expertise. There have been several studies on, especially like buprenorphine, and other medically assisted treatment, to see kind of how that. We basically see the same results. The groups are different. I worked at the VA for a little while, and the folks who are on methadone, it's different. There's a lot of sleepiness, there's a lot of just kind of feelings about being on it, wanting to go off it, that kind of thing. That study I talked about with the women, they were on methadone maintenance. So I think it's something to certainly keep paying attention to because it's out there and it's what folks are doing. I haven't done like a really like 2x2 on medication, not randomized to control randomized to PRP. That would be very interesting, perhaps. But I mean, we're all clinical psychologists and we don't do medication trials, so other folks have looked at basically, is this effective for people who are doing medically assisted treatment?
Thanks.
I'm curious about the last study you mentioned and sort of the sustainability. And I think if I heard right, the folks who are facilitating the groups are volunteers, and so they're donating their time. And so I'm curious about sort of like thoughts and ideas that you all have had, or what you thought about sort of the long-term plan. Is there a repository of people, volunteers that we can get and organize, or and then you start thinking about the funding, like about Zoom, and you've got to have whoever's delivering it has to have a platform for that. And I'm just curious about, I'm sure it's not well developed, or I'm guessing it's not well developed, but I'm curious about what y'all have thought along those kinds of lines in terms of this accessibility mission of making it accessible.
Yeah, great. So question about sustainability and all the things that it would take to have this, like, there has to be some funding or platform there, like Zoom has to be there, and there has to be folks who are willing to facilitate this forever or however long. We have a core group of folks, we had 14 who volunteered for the trial. Again, we chose to have them volunteer because we wanted to see if this is sustainable. Are people even willing to do this? Those folks they're solid, they're wonderful. I meet with them twice a month just as a support, really, just to hear how it's going and how can I be supportive. At the end of this trial, we have to wait till we've collected the final 12-month data. And then the idea is we have a listserv that has about 500 people who have been trained in MBRP. And I'm going to post on there, anyone who wants to do these groups, I will support you in whatever way I can. It won't be financial. This is a peer-led kind of system. But if you're interested in doing this, you want to co-lead, you want to lead your own group, come on in. We'll see. If I really don't know what's going to happen. I mean, the dream is that if people will want to do it, that folks who are facilitating seem to get a lot out of it. And they really enjoy it. They get a lot from just hearing the experiences and practicing with these folks. So my hope, we'll see. And then as far as all we really need in terms of technology is Zoom. And most of the folks have a Zoom platform. If they don't, we'll find money somewhere to get a professional Zoom subscription. Yeah.
Can I ask a follow-up about that? Because I do a lot of implementation research, so I think about these kinds of things all the time, but I was thinking about fidelity and sort of like, you could have a lot of people volunteering to lead groups, but in 3 years, are they still doing the model? Or have we kind of drifted off and this facilitator really thinks these things and let's bring this in? And so I'm curious about what y'all have thought around that, or ideas around that.
Yeah, question about fidelity, especially over long periods of time, different clinicians. For the study we're doing, we're coding for fidelity. We have a fidelity measure. So within this study period, these 3+ years, the sessions, randomized, I think 50% will be coded. And in this, we're really coding for intention rather than more function than form. So in some groups, people are like, let's make it a little more fun because the energy is a little low, and let's do this. And in other groups, it's like very somber, and it might be a shorter practice because the attention spans are different. That is fine. What I'm interested in, what fidelity in this program really is do you know what you're doing? Do you understand why you're doing this? And you can do it however you need to do it. It doesn't have to be a raisin. It can be 10 minutes. It can be 2 minutes. Do you understand the function of what you're doing? It's challenging to try to make our fidelity measure match that. Over time, I don't know what folks are going to do. I am on board. So if people want to do this and want to meet, I want to have an eye on that. I don't know how much control we'll have. I think support is what I'm most interested in. And anyone who's willing to do this, yes, great. How can I support you? And, do you have questions about what's going on in there? We're recording sessions now. I don't know if after this study we probably won't continue to. I'm not sure about that. So I don't know if I'll have as much sort of say and eyes on. Yeah. It's a great question. No, we absolutely think about it. Yeah, thank you. I think, yeah, maybe one more. Yeah.
One more. So I'm most familiar with like the stress reduction mindfulness practice, right? And so especially when you were talking about like the first study with exposure, that population I don't think had a risk of re-engaging because they were in a facility, but just processing through some of these experiences they've had or even the cravings, like can the mindfulness actually be a trigger for engaging in these behaviors? And if that is a possibility, how do you counter that?
Yeah, so question about can mindfulness actually, I mean, contact with these experiences and triggers
Sure.
actually be a risk factor for engaging in use? In the first years that the urge surfing, I mean, we're asking people session 2, come bring to mind and body something that's really difficult for you to be with. And that scared us, and we learned quickly, like, make it a 2 out of 10. Not the hardest thing you're working with, but like someone in traffic just kind of annoyed you today, or that in meeting when that guy won't shut up, whatever it might be, something that you can kind of work with. So that it's practicing with littler, smaller waves. My sense is, I mean, we also, at the end of each session, we do a 1-word checkout. It's basically, what's happening for you right now. And it gives a nice kind of overview of like, oh, relaxed, craving, scared, it's like, okay, do you want to hang out and chat afterwards? It happens a lot less than I think I feared in the beginning. But even within that first trial, people were out on the spigot use. Some of them were, court mandated and had UTOXs, so they had other motivating factors, but people relapsed all the time in that, in treatment. So it wasn't a
Sure.
completely prohibitive, yeah. Thanks. Okay, I think we've got 2 minutes. We can end early. Okay, thank you guys so much. I appreciate your questions and your attention.
Yeah.
Thanks so much, everybody. Just a quick announcement again. Remember, this is a monthly series, so I hope to see you all again next month. We'll have our very own Dr. Nate Williams will be presenting next month. So please, if you haven't, spread the word to friends and family, whomever, anyone's welcome to come. And make sure to register so we just get an accurate head count, and folks who need to be on Zoom as well. Thank you for being here, everyone. Thank you.
Come watch you.
I haven't, about the details.